Hello, everybody. Thank you, Dr. Niamchu and Dr. Obaji, and to the Academy for inviting me here. I'm a cosmetic surgeon, and I have offices in Santa Rosa and Napa, California, and I have a boondoggle office in Maui. But Joe, you're welcome anytime to come and visit. So this is actually, I have no disclosures, and this slide here is actually from the California Academy of Cosmetic Surgery meeting this last fall. Dr. Michael Morissette was president, and was kind enough to invite me to speak. And this slide, the title, kind of expresses the way that I think that we should come to these meetings. We heard a lecture on duality by Dr. Naveen earlier today. My duality when I come here is that I want to be open-minded, but I also want to be skeptical. So I'm actually hoping that I will kind of convince the ones who are skeptic about using acellular adipose matrix tissue and convert you to wanting to at least try that in your office if you can. Let me make sure that I get this correctly. Okay. This slide makes me sad. Mark Berman was my mentor for fat grafting, became a friend, amazing colleague, innovator. The world has great loss by not having him here. And I always want to acknowledge him whenever I discuss fat grafting in any fashion. And thank you, Keto, for mentioning him as well. Okay, so fat graft. Let's talk about, I'm not going to go into a lot about beautiful lecture, Dr. Barad, on acellular adipose matrix tissue. So you covered a lot of the biology of that. I'm going to talk a little bit more clinically about how to use it. So this is one of my patients, a colleague, a nurse, who you can see her pre-treatment. And then what I did was perform. She was, I think, my third patient that I performed fat grafting on after seeing Dr. Berman down in Santa Monica. And I only injected 20 cc's of her autologous fat. Okay, 20 cc's. You start off slowly when you try a new technique, and then as you gain confidence, you begin to inject more. Nowadays, I'm injecting anywhere from 40 to 60 plus cc's of fat when I do pan-facial rejuvenation. So we see after her first treatment at 6 weeks out, we can see the improvement. But because I only put in 20 cc's, both she and I wanted more. So I had originally done liposuction on an area for, I can't remember what part of her body that I did it on. And what I had learned from Dr. Berman was I labeled it, and I stored it sterilely in a freezer, just a freezer, okay. And then we brought her back. Actually, and correct me if I'm wrong, Dr. Abaji, I think you did a study at the University of Pittsburgh. Radiographically, you followed fat grafting, and I believe the conclusion was that 3 months, what you see is what you're going to keep. Is good. I've been quoting you correctly. Good, after all these years. Perfect. So I waited 3 months, and then I went ahead and we did a second session, and I put another 20 cc's of fat in her face. I'm going to go to this one here. So as I was describing this in another meeting, Dr. Guillermo Blugerman heard me talk about this, putting fat in the freezer and so forth. And he was kind of nodding his head at acknowledgement like, yeah, that's what we used to do. Okay, let's go back. So many of you, if you're skeptical, say, well, the fat cells died. Who are you trying to fool? You know, you just thawed it out and you injected it into the face. And certainly Dr. Yoshimura then did studies and said even with fresh autologous fat grafting, we think, simplistically, we put in fat, we put in micro droplets, we're going to get angiogenesis, those cells are going to survive. But indeed, his theory was that all the fat that we put in, most of it actually will die, but we stimulate the stem cell cascade, and then what happens, because we put this target in, that we get differentiation of stem cells to then convert into fat cells, adipoblasts, then into adipocytes. And that was the theory. So it's my theory that even though we use what might have been lacking viable adipocytes in the second session, that you can still get long-term results. How did we get this if those cells were dead? And so as fat grafting, and we used to have a lot of lectures on that, and I would listen to all these, and Dr. Berman and Dr. Obaji would be there, and I made all those lectures. We can see that over time, probably as the theories arose, what we were doing practically made some sense. And so we got long-term results. That's 9 years later that you can see, okay? All right, so I'm not going to go through this right now because Dr. Barad did that. You may or may not know that I was actually a organ transplant surgeon. I was a general vascular organ transplant surgeon. That was my core. So I was the one who would go in the middle of the night and we would harvest livers and pancreases and kidneys. At that point, then, we would leave the room, and these were obviously wonderful human beings who would donate their organs for medicine and for others. But then the technicians would come in and they would harvest the skin and the fat and the bones. And so this particular product that's out now, produced by a company, we'll keep it generic here, was initially started off as a bone tissue bank, okay? So everything's been processed as would be appropriate in the days when I was an organ transplant surgeon, okay? So I'm gonna skip through these. And that was the process. So I'm just on this slide here, I'm not going to reread it. Dr. Barad already described it, but just if you think, okay, seems like I might trust this guy, but is it really true? You know, you put in cadaver fat, if you will, and it's going to create new fat. I can just, as from a personal testament, tell you I'm old enough that I had some gingival disease. I needed to have surgery. I had some bone resorption. So my dentist didn't really even talk to me much about it, but he was going to put a cadaver bone graft in as well to give some support. So he did that for me. And so initially you get support from the tissue that's been implanted or transplanted. Then macrophages begin to go in and begin to break down that tissue. You get fibrosis. But indeed, what happens, because we put that target tissue in, we then get differentiation of the stem cells, and now my stem cells are converting into osteoblasts and then into osteocytes. So that's the process, if you want to think of everyday example of this concept of tissue transfer or tissue creation or regeneration. So this is, let's see, will it go? Okay, great. It does have a toothpaste, I believe, agree with Roxana, toothpaste-like consistency. It has to be diluted some. So basically, I take a half cc of normal saline and a half cc of lidocaine, and we put it together, and then we just pass it back and forth, and everybody will have their own sort of protocols. I just do it 10 times. We'll keep on going. So this young lady is I think she's a nurse, maybe a PA. She does a great job with, I like her because she's really educational in her posts. And so I got her permission to use this. I love her moniker, Ms. Glotox. And so what we did was she drew off what we see as facial deflation, okay, and it makes your brow sit lower. And then she drew on her face the area that she considers the temple, and that when you do that, it supports it and raises the brow. I agree with this somewhat, but I would say is that I would take it one step further. And I think that we need to revolumize even more aggressively than in the area that she's mentioning. So if we look at the, I guess there's not a pointer. Is there a pointer? Oh, on the mouse. Okay. So if we look at this here, great. Okay, we can see the temple area here. It's very deep, and the frontal prominence right there. I think that's an important landmark. Also, if you look down here and you see how huge this temple is, most of us who started using PLLA, we were taught to take that PLLA, go into the temple really deep. It's a lot deeper than you think it is. You think you're sticking it into the temporal lobe, and feel you hit the periosteum and then you inject it. But indeed, Dr. Sadati, I was on a panel with him at another meeting, and his comment was I think he showed a similar slide. He says, if you're putting the needle right down in the periosteum, you're beginning to revolumize underneath the muscle into the aponeurosis. So what are we doing? And since then, he made me inject more superficially. And I know from my experience with fat grafting that what I do is actually, I'm more superficial. I don't actually put a lot of fat deep in the temporal fossa. So this is our practice administrator. She's a spin instructor. You can see she looks great. Years go by, and you can see the aging process, right, of facial deflation. And in particular, if you look at her temple area, you can see how she is indeed deflated in this area here, okay? And some people may even see, does she need a bluff, or has her brow dropped? Okay. So This is just me, you all know how to inject local anesthetic, keep on going. So I do to mess. I'm kind of an empath, so I don't like my patients to hurt. So I use basically a 0.2% Klein solution. And the key here is that I like to, and I maybe only use anywhere from 2 to 3 cc's, but I come way up in this area here, right up in the roof area, as Dr. Broad described, under the brow and up along the frontal prominence here. I'm going to keep on moving so I don't run out of time. So now what we have here is now we have the diluted acellular adipose tissue matrix. And so I'm going way up high, a lot higher, I think, than most people would. I'm aiming up for the prominence right here, the frontal prominence. Okay, and I only use a cannula. Dr. Broad has a lot more chutzpah than me. I will not use a needle. I use a 22 gauge cannula, and I very rarely have to change it for having it clog. Okay, so that's it. I am, thank you. I am sub-Q, so I'm not going deep. Okay, when I have a lot more fat, autologous fat grafting, I go deeper, I go in layers. Because of the cost of the product, I use it sub-Q, okay? Probably for me, the limiting factor of this technology is just cost, and that's just the realities of our practice. And so here we go, and just on the contralateral side, and again, just to show you this, I'm gonna go slowly here, because I kind of want to really define the areas that I treat, then I'll show you some before and afters, and we'll finish close to on time here. So you can see that I'm aiming up towards the lateral brow into the roof area. I'm actually a little bit higher than I wanted. I actually will go directly under the hair growth is where I will come. And you can see retrograde. I do use my thenar eminence as opposed to my thumb. I think that you have better control. You don't put as much in a big bolus in. Learned that from Dr. Berman. Okay, and then I move it out towards the hairline. And so I got 30 seconds, so I'm going to move quickly. All right, so here we go. We have, so you can see this is the area that I would inject with the fat. And then I think you can see that, I hope you can see that on there. The TV's a little bit better quality, but you can see where the cadaver fat was placed, okay? And this is at 2 weeks out, so you can see how it nicely lifts. Okay, now of course there's some swelling that will go down, but you can see how it nicely lifts. And I'm gonna kind of use 3 months is when I'm gonna do the next injection, thinking that that's when you're gonna be seeing the adipocytes being laid down by the body. So you can see the improvement here and here. Now this lady here, you might say, oh, that's just Botox. Actually, the pre-treatment photo is before neuromodulators and cadaver fat intertemporal area. This is 3 to 4 months later, so the neuromodulators should be wearing off. So she got a fairly significant lift here, which surprised me. Okay, the others are a little more subtle. This is a 40-plus-year-old woman, and you can see her before and after photos looking at the temple area. And I just take these photos with an iPad. I do not change any lighting or anything. So if you can tell me why the pigment looks different on the skin later on, some techno person can tell me maybe it's just makeup, but I don't try to doctor these at all. And so you can see the improvement here. Okay, and it's just in the same room, same lighting. The last patient here is 40-plus-year-old young lady, and she had treatment here. She is a believer in aesthetics. We just do little treatments continually, and you can see the improvement here, and ultimately that's what we want to get a brow lift. I do think that we're gonna see good results. I'm only out a year. I don't know how long it's gonna be long-term, but I'm anticipating that we'll get years of improvement with this treatment, and ultimately ultimately what we want to do is to have our patients feel confident about themselves. Thank you very much.